So I'll proceed. So what we're going to talk about here are the treatments for various states of prostate cancer. And so when you talk about prostate cancer, as this audience probably knows, there are a number of prostate cancer isn't just one disease, it's a number of different states. And so when we're talking about any specific treatment, we have to then think about, well, what exact state are we talking about? And so what you can see here is that over on the left, there's local or locally advanced prostate cancer. That's someone with a new diagnosis. They may have definitive therapy such as radiation or surgical treatment. And then if there's a recurrence of cancer with a rising PSA after treatment, then hopefully that's just the only evidence that you have of the cancer. That's so-called non-metastatic hormone-sensitive prostate cancer, sometimes also called just a PSA recurrent or a biochemical recurrence because you have a rising PSA, but the scans are clean. Um, so, so often those patients may get treated on some sort of therapy, especially if there's a high risk. And the disease may ultimately progress to castration-resistant disease without any evidence of spots on scans. That's the non-metastatic CRPC at the bottom. Or unfortunately, if it becomes metastatic and visible on scans, and we call that metastatic CRPC, castration-resistant prostate cancer. The other path is if you develop metastatic disease after having had definitive treatment, or for those men who are diagnosed with metastatic disease at the very beginning. Metastatic here meaning spread of cancer. And we'll call that metastatic hormone-sensitive prostate cancer. And that is another disease space that we're going to talk about today. So I'll cover a lot of these different diseases, and I'll try to talk about relevant clinical trials and relevant FDA approvals in those spaces. A couple of key definitions I'm just going to lay out for you. We talk about ADT or androgen deprivation therapy. That's also sometimes called castration therapy. And the goal is exactly how it sounds, just to tell the testicles to stop making testosterone, tell the testicles to stop working. So that can happen either surgically, which happens in a lot of other areas of the world that don't have access to certain medicines that we have. And that's removal of the testicles. Or there's medical castration, which is either in the form of drugs like leuprolide or Lupron. Those are called GnRH agonists, or the antagonist called Degarelix or Firmagon, or the pill form called Relugolix or Orgovyx. When we talk about castration-resistant disease, that's when the cancer is growing despite the fact that the testosterone is at the castrate level. And that's with a rising PSA, worse disease on scans, and symptoms attributed to prostate cancer. So hopefully the sorts of trials I'm going to talk about today will make more sense as we talk about these different terms. When we talk about the hormonal therapies, we talk about the androgen receptor. Testosterone belongs to a class of hormones that are called androgens. So when we talk about androgen deprivation therapy, what we're doing is we're depriving the body of those androgens like testosterone. And so when we then talk about androgen receptor, that's the receptor, the protein that testosterone binds to in the cancer cell that then tells the cell it's time to divide. And so there's a lot of different ways that we are exploiting the testosterone as the fuel for prostate cancer cells. Now, on the left here are the GnRH agonists or antagonists. So those are drugs I already mentioned to you. That's ADT, things like Lupron or things like Relugolix or Orgovyx. These tell the testicles to stop making testosterone. In the middle are the androgen receptor inhibitors. Sometimes we call these anti-androgens. These just block the action of the testosterone from hitting the androgen receptor and therefore stimulating the cancer cell to grow. The more recent generation of these drugs include apalutamide, enzalutamide, darolutamide. You're going to hear me talk about those during the course of this talk as well. And some of you may actually have experience with this. And then over here on the right is abiraterone. It's also called Zytiga. Abiraterone works by stopping the production of testosterone in other sources other than the testicles, because the testicles will be shut down by the Lupron. The abiraterone shuts down production of testosterone from other sources like the adrenal glands or the cancer cells themselves. So that's how we use these different androgen receptor pathway inhibitors, sometimes called ARPs. Because prostate cancer is a disease that we're trying to push into the chronic disease category, even if it's metastatic, then what's one thing that I tell primary care doctors is I try to familiarize them with the side effects of these treatments, because these are men that we will be treating together for hopefully for many years. So when we talk about ADT or so-called castration therapy, there are a number of different side effects that can happen that are all very similar to women undergoing menopause. For the ARPs, AR pathway inhibitors I just mentioned, there's the list of potential side effects in the middle. And then way over on the right is chemotherapy. And chemotherapy is used a lot in prostate cancer patients, especially in the metastatic setting. And that has the side effects that I think most people are familiar with. Um, However, usually with prostate cancer, we're just giving one chemotherapy drug at a time. And in terms of the side effects that most people are most concerned about with chemotherapy, when you use multiple drugs at a time, that's when those side effects get really compounded. When you use one drug at a time, it's actually better tolerated than most men actually have assumed. So it's one thing to bear in mind. Now, when we think about prostate cancer, and if I look back at where we were in 2010, this is my little construct of the prostate cancer patient's journey, where the man starts over here on the left with localized disease, has surgery or radiation, and if unfortunately the cancer comes back and becomes recurrent or spreads, then the treatments we have are castration therapy or ADT. Then at that time, we then just had chemotherapy, docetaxel, and a couple of other hormonal therapies that were not as potent as what we've got today. So that's how we treated this disease back in 2010. If I fast forward to the last time I gave this talk in 2019, this is what I started with in that talk in 2019, saying that, that there were a number of these drugs, some of which you're going to hear about today, that became FDA approved and have certainly improved the survival of men with prostate cancer. And in 2019, these are the drugs in yellow that I really highlighted in terms of the clinical trials that were relatively new at that moment. If I fast forward to the sneak preview of today's discussion, this is kind of the landscape between 2019 to now, where in yellow are all these different therapies that have become FDA approved and very commonly used for this disease. And my task for today is to talk about the trials that led to these FDA approvals. So I'm going to bring you through these relatively quickly. I apologize for the speed.
No, no, no.
A couple of basics, though. For us to talk about clinical trials, we have to try to understand the data. So I'm not going to try to turn you all into oncologists here, but I'm going to try to tell you how we think about these studies. So when we think about these studies, we think about the number of patients. What is a treatment arm? What is a drug that's being tested, and what's being compared against? That's usually the control arm, meaning the standard of care. Was there adequate follow-up, and were the findings statistically significant? So when we try to think about the data, we talk about survival curves. I'm going to show you a bunch of these today. So it's good for you to get experience with this. These are also called Kaplan-Meier curves. When we think about these treatments, we will show the percentage of patients who are still alive. This is a survival curve. And if you're testing treatment A compared with treatment B, what you're hoping for is some daylight between these curves, because you're trying to show that treatment A is superior to treatment B. And that's the arrow that I'm showing here is at the 50% line. That's the change in median overall survival. How long does a group in treatment A before 50% of those men progress or pass away, as compared to 50% in treatment B? And we're hoping that these curves are separate from each other. You'll see some good examples of this. Here's a poor example of this. Here's an example of a trial where, and I didn't show you what the drugs are because it doesn't matter. But what I want you to appreciate here is that there's no daylight between those curves, because the treatments were no different from each other. So now that you're experts on Kaplan-Meier survival curves, here are some examples from a previous talk. We're not going to go through these trials. It's just for you to look to take a 50,000-foot view and see that here are examples where the curves separate. And that is why these different drugs, as listed here, led to FDA approvals, because these men who were treated in these clinical trials, these brave men who participated in these trials, had an improvement in overall survival, or demonstrated improvement in overall survival. And you can see how those curves separate. So the first disease state that I'm going to tackle is biochemical recurrence. These are patients who've had treatment, either prostatectomy, removal of prostate, or radiation therapy, but the PSA is rising. So we have some sense that the disease has not been cured. So that's sometimes called the non-metastatic HSPC state. And biochemical recurrence or PSA recurrence is a tricky space here because these are men who don't, you scan them and they don't have no evidence of the disease. So they don't have symptoms because they don't have metastatic cancers. They don't have symptoms. It is typically a long natural history. Prostate cancer is usually a disease of older men. And as men get older, there are other competing causes for death. So what we have to be careful about is that many of these men may never suffer or die from metastatic disease, and that treatments, because these men don't have metastasis and have no symptoms usually from the cancer, treatments can only cause harm. So we have to make sure that treatments are doing a good job at controlling the cancer, but also limiting side effects. Now, what we think about is that when patients have a doubling time that's less than 9 months, a PSA doubling time of less than 9 months, meaning the PSA is rising relatively rapidly, they're the men at high risk for progression, the increased risk of what was listed here as PCSM, prostate cancer specific mortality. That's dying of prostate cancer. Now, most of those men are managed with intermittent hormone therapy, which is giving ADT or taking away testosterone for a certain period of time. And that's been a well-worn path since 2012. I will note this is a shrinking group because PSMA PET scans, as you all may have heard about, are much more sensitive than the scans that we used to use. And so there are very, very few patients now who can have a rising PSA with a fast doubling time where we actually don't find spread of cancer. But this study is the EMBARK trial, and this is just a schematic of what the trial is. In these patients who had no evidence of cancer on their scans, but had a PSA doubling time of less than 9 months, were randomized between enzalutamide, sometimes called Xtandi, that's the trade name, just by itself, or a combination of enzalutamide with ADT, or just ADT alone. And if those patients had a nice response, they could stop their therapy and be treated in an intermittent fashion. These are patients they were scanned with regular CAT scans and bone scans. And so what did EMBARK tell us? It showed that the metastasis-free survival, that's the curve up here in the upper left, was improved when you gave enzalutamide with luprolide, that's a combined therapy, as compared to luprolide alone for these patients who are at high risk for progression. Similarly, enzalutamide monotherapy, just by itself, no ADT, had an improvement in metastasis-free survival. You can see that those curves separate. And in this case, what we're talking about is delay of metastasis. When they looked at overall survival, did it help these men actually live longer? Of course, that is what we really want to do. We want to control the cancer, but we also want to make this a chronic disease where these men are living longer. But in this case, the overall survival, meaning how long do these men living, that data was not yet mature. Notably, on the study of 130 men who had passed away on the study, only 53 or 41% have died of prostate cancer. That's an important statistic because that's a lot like other trials that have shown that about 60% of men die of other causes, usually things like cardiovascular disease, which is why I was describing to you that we need to give therapies that are going to cause little harm but have big benefit. And what we also have to do is tell men they really need to work on things like cardiovascular disease, making certain they take care of the rest of themselves because they're going to be managing this for years. And you can see here this overall survival at the bottom axis here goes out to 96 months. We're talking about 8 years here, and you can see how many of those men are still alive, about 80%. So this is it's so important for us to talk about quality of life and how do we help men live the best lives that they can. So are there specific patients we should consider? This is a different type of plot that, as you're learning how to become a statistician here and a medical oncologist, when we look at these sorts of plots, what we see is we're trying to identify who are those little groups of men where they may benefit most from this sort of therapy. And if we see that the bar is to the left of the number one here, that favors the drug combination. In this case, the patients who seem to benefit the most had the shortest doubling time, meaning the fastest growing disease, whereas patients who had doubling times of 6 to 9 months maybe really didn't really benefit from the addition of enzalutamide. So when I think about this, I have to be very careful about thinking about, do I want to add other potential side effects? Because enzalutamide patients had more fatigue, even had some seizures. So we must think about the side effects as well. Ultimately, the FDA approved this for enzalutamide for PSA only recurrence in November 2023. Next, I'm going to move on to the patients with newly diagnosed metastatic prostate cancer. This is so-called hormone-sensitive prostate cancer or castration-sensitive disease. As I mentioned, you can get here either by being diagnosed for the first time with prostate cancer, cancer in the prostate, but also spread to other places, or if a man's had prior therapy and then develops recurrence of the disease and metastatic cancer. What I've previously talked about, and for those of you who were with us in 2019 for this talk, that we've been able to show that when you add treatments to ADT, things like abiraterone, apalutamide, enzalutamide, that you can actually improve the overall survival for these patients. And importantly, the endpoints of these trials included overall survival. So we know that intensifying therapy can be helpful. Two trials here, though, showed that in patients who are candidates for chemotherapy, so high volume of disease, where the doctors felt like they could tolerate chemotherapy and that chemotherapy was indicated, these studies showed that if you gave triplet therapy, so no longer just doublet therapy, if you gave triplet of ADT, castration therapy, plus docetaxel chemotherapy, plus either abiraterone or darolutamide, that we actually showed an improvement in overall survival. So these are trials 2 and 3 of the big trials I'm going to show you today. This is just a schematic from the trial with darolutamide, just describing the schematic of how patients were selected and then ultimately got randomized. These are overall survival curves for both abiraterone here on the left and darolutamide here on the right. My experts in statistics now, you all can see that these curves separate. And what these showed is that there's a statistically significant improvement in overall survival when you give triplet therapy for the patients who are best candidates for that. And those are patients who have cancer that's spread to what we call visceral organs like lung, liver, or patients who have 4 or more bone spots, at least one of which is outside of the spine and pelvis. So those are the patients who are the best candidates for docetaxel. I would argue that those patients should be getting triplet therapy. The fourth trial I'll note is this AirNote study that was published recently. This was another doublet therapy. So these are in patients who got ADT and either darolutamide or Nubeqa or placebo. In this case, the primary endpoint was progression-free survival. This occurred in the last couple of years. 70% of the patients had high volume disease. And what you can see here is that it met its primary endpoint. The curves separate here. This is progression-free survival. So how long before the patient progressed on this therapy. You can see that the group that received darolutamide, that's the curve that's denoted in black with little circles as compared with gray, that the patients with darolutamide did better than patients who got placebo. One thing I'll note is that they haven't had a mature set of overall survival. So does this help men live longer? That wasn't mature at the time of this publication. So it's a little bit different from some of the other trials that I've shown you. But the FDA did approve this just a couple of months ago as doublet therapy for this disease state. So I think it's a really good news story for patients with high volume, newly diagnosed metastatic hormone-sensitive prostate cancer. What we've seen here is that when we used to just give hormone therapy alone, ADT alone, that survival was only 33 to 35 months, so just under 3 years. And what we've seen is these iterative improvements as we've intensified therapy up to 61 months in this triplet therapy with abiraterone, and it's not yet been reported for the darolutamide triplet. So I think hopefully this is giving us all hope that our treatments are getting better, men are living longer, and with that, we also have to help men live better as they live longer. Now I'm going to move to the last disease state, which is castration-resistant prostate cancer. I'm going to buzz through a bunch of different studies here. Hopefully, because we started a little bit late, I've got a couple extra minutes. So one of the drugs that's got a lot of attention was called Pluvicto, lutetium PSMA 617, also called radioligand therapy. This is a radioactive particle linked to a molecule that will find prostate cancer cells that express the PSMA protein. Now, this is the VISION trial that looked at patients with castration-resistant prostate cancer. They've had a prior AR pathway antagonist. They also have had prior chemotherapy. They had to have a PET scan that showed that their disease expressed PSMA, and they went on to receive either lutetium or what's considered the standard of care. So here, this is the primary endpoint is overall survival. This study showed that the Pluvicto met its primary endpoints, including progression-free survival in the top left, overall survival. You see those curves separate. They separate relatively early and remain separate. And the time to first symptomatic skeletal event. That's important because we're talking about symptoms and how do men feel. The bottom right corner just describes the PSA response. So men with prostate cancer are wedded to that PSA number because they know their number. In this case, with Pluvicto, only about 46% actually had a greater than 50% reduction in PSA. So one of the challenges I would just say with Pluvicto is that we have men who are having responses and they're actually living longer or their disease seems to be shrinking, but the PSA doesn't really match up with that. And so that can be a little disheartening. And that's when we have to help men understand that sometimes the PSA doesn't tell us everything. I'm going to move a little further in terms of safety. Generally speaking, this is a relatively safe treatment, but there were 5 adverse events that did lead to deaths. And I mention this only because when Pluvicto first had press releases, many of my patients were calling asking for Pluvicto. And I think we always have to exercise a little bit of caution that we understand the side effects as well as the benefits. I'll mention that the FDA did grant breakthrough therapy designation and then full approval in 2022. So it was good for patients who already received chemo. Then it was tested for patients prior to getting chemotherapy. This is called the PSMA-4 study. Very similar setup here. And I'll just skip to the chase here. The patients who received the Pluvicto, that's the blue curve here in the upper left, had an improvement in progression-free survival. So you could see those curves separate. That was the primary endpoint here. They showed that it controlled the disease better. Now, overall survival over here in the top right, there was no difference. And there are a number of different reasons for us to consider that. It's a little bit more detail than I can give for just today's talk. But bottom screen here just shows that, again, about 50% of patients had a PSA response. And this led to FDA approval in just about 6 months ago. So important, we're making advances still. I think that's really, really important. The last category of drugs I'm going to talk about, and these are a number of trials I'm going to buzz through here, had to do with PARP inhibitors. And I think this is an important category because we're trying to personalize treatments for patients. And I think that for this group, what I really want you to understand is that there's a category of patients called homologous recombination who have homologous recombination mutations, usually the BRCA1 or BRCA2 genes. You may be familiar with that in breast cancer. So women with breast cancer may be tested for BRCA because it leads to higher rates of ovarian and breast cancers. But men who have these mutations also have a higher rate of prostate cancer. That's why it's really important for us when we find men with new diagnoses of prostate cancer that we are testing to see, did you inherit anything from mom or dad? And I would just say that for most Black patients, African-American patients, that we probably don't have enough genetic information in the big databases for our understanding, or our best understanding of management of this disease in this population. So I'm going to, again, strongly encourage all men who have metastatic disease to get hereditary germline testing, and particularly for my patients who are Black. So there are 6 different DNA repair pathways in human cells, and homologous recombination, which is managed by the BRCA pathway, is a major one. Too much science for us to go through, but it's just to tell you that when you have a mutation in that BRCA pathway and you treat with a PARP inhibitor, which inhibits a different pathway, those patients are particularly susceptible to that class of drugs. Now, this has been studied in a number of different trials, including the use of olaparib, which is also called Lynparza, in patients who have already received prior chemotherapy and prior hormonal therapies. Here you can see these are overall survival curves of groups of patients who have these BRCA1 and 2 mutations. So the group that received olaparib is in blue, as compared to the patients who received other types of standard therapies in red. You can see that there's improvement in overall survival in this group on the left, maybe not as much of a change in the group on the right that have fewer patients with these sorts of mutations in this same pathway. But it did lead to FDA approval of olaparib for these patients who had these mutations. Very similarly, the drug rucaparib is another PARP inhibitor, and this was studied in patients with BRCA1 and 2 mutations. This is a different way of looking at data, looking at PSA responses or radiographic responses. How much change did they see or improvements did they see? And one thing you can see here is that there was improvement of 50 to 55% in patients who received rucaparib, and that led to FDA approval in 2020 as well. The last group of trials have to do with combinations of these PARP inhibitors along with then these ARPIs. So in 2023, this big meeting brought on 3 different trials that all basically were showing combinations of therapies. And so I'll very quickly describe these. One was olaparib with abiraterone compared with placebo and abiraterone. When they tested this combination in just a whole big group of men with prostate cancer, you can see maybe there's some separation later of these 2 curves. The patient who got olaparib is in blue. But if you separate it out by the patients who had a mutation versus those who had no mutation, you can see that the patient at the bottom left, there was an improvement. There's a separation of the curves eventually, and an improvement in overall survival in the patients who have a mutation. But if you don't have a mutation, you're not really going to benefit from getting this olaparib, which is important because olaparib also has side effects, including more anemia, even things like myelodysplastic syndrome, which is a problem with your bone marrow, can even lead to leukemia in extreme cases. So this led to FDA approval in May of 2023 of this combination. The TALPRO-2 study has been described in a number of different ways, and the most recent description was the overall survival data, very similar to the previous study. Looked at enzalutamide and talazoparib, or placebo with talazoparib. Or enzalutamide with placebo. And here you can see, again, if you look at all the patients, maybe there's an improvement when you add talazoparib. That's the red curve. You separate it out between the patients who have a mutation or patients who don't have a mutation. You can pretty clearly see that there's a wide gap here that opens up in terms of overall survival if you have a mutation when you get the talazoparib with enzalutamide, but no difference if you don't have a mutation. That led to FDA approval as well in June of 2023. The last one is this magnitude trial. This looked at niraparib, another PARP inhibitor with abiraterone. In this study, they only looked at patients who had a mutation. And here what they saw was that there was an improvement in progression-free survival, but no improvement or very little difference in terms of overall survival. But that did lead to FDA approval of this combination. So if you're a patient who has one of these mutations, you've got different therapy options than some of the other patients who don't have such mutations. So there's been a lot of progress. These are the FDA approvals that we've talked about today. I try to put them into the disease spaces so that you can sort of understand kind of where we've been. And I'll just say that there's been a lot of evolution from 2019. I tried to show you where these drugs in yellow have fit. With that, I'm happy to take your questions. It's been a great pleasure and an honor to present to this group.
I
There's
want
my
to take
contact information.
Okay. I want everybody to take a nice shot of that. And I want everybody to kind of give Dr. Lee applause, a virtual applause, because this was a very complicated area over the past 6 years. Look at what's happened and look at where we're going. I have some questions that we pulled up. And there was a question about intensification. Could you better help folks understand this whole concept of intensification? Because some patients are just receiving an ADT and going home and don't know that about this doublet and triplet therapy approach. Could you better explain that?
Yeah, so doublet and triplet therapy, ever since 2014 at one of our big meetings, it was proven that adding additional therapy, intensification, helps men live longer. And so I would just say that for most men with metastatic prostate cancer, at the newly diagnosed metastatic prostate cancer, having just ADT is probably not the standard of care in today's day and age. And if you were to look at national guidelines, the National Comprehensive Cancer Network, the AUA, they would support intensification, adding either another hormonal agent, the ARPIs that I've mentioned, and of those, there's an overall survival benefit to having those drugs. If you had what's called high volume disease, as I mentioned before, that's having spots in the liver or lungs or spots outside of the bones, or at least four bone spots with one outside of the spine and pelvis, that those patients really benefited from getting chemotherapy as well, and as well as another hormonal agent. So that those are the patients that get triplet therapy. In today's day and age, I will say though that when talking with my colleagues, there are certainly going to be some patients where you only want to give just the ADT, just the Lupron or Relugolix, because of the other medical issues that the patient faces, or age or frailty. Because again, whenever we talk about intensification, we're also talking potentially about intensifying side effects. So we have to
Right.
think about the patient sitting in the room, not just as an abstract patient, but as a man who's got medical issues.
Mhm. Thank you for that response. The next question. This is interesting. You talked about making prostate cancer this chronic disease, or your journey being more of a treating it like it's a chronic disease. What wasn't brought up was is this: it, you have the drugs and the treatments, and the cancer itself can impact your bone health. W- Are men supposed to be receiving bone scans to look at the quality of health? Because if they get a fracture, that's going to change the quality of health.
Yeah, so certainly men on ADT, and Dr. Morgan's it has expertise in survivorship. So this is really important to understand that men with on ADT have their bones thinning, just like women going through menopause. They lose density in their bones. So what we typically will do is have men supplement with calcium and vitamin D from the very beginning to try to keep calcium in those bones. We counsel weight-bearing exercise, which is walking 45 to 60 minutes a day, not necessarily weightlifting, but weight-bearing exercise, putting pressure in the pelvis and long bones, keep calcium in those bones, and then do a bone density test, so-called DEXA scan, bone mineral density test. Not a bone scan to look for cancer spots in the bones, but bone density or DEXA scan to look at how thick or thin are the bones. And perhaps periodically repeat those tests, especially if they show thinning of the bones. And sometimes we have to add medications for patients who are developing things like osteopenia, thin bones, or osteoporosis, very thin bones. Very important to prevent fractures.
Yeah. And so, I mean, I just wanted to flag. So when should they get screened? Should they be getting bone scans?
So a bone mineral density test or a
Right.
DEXA scan, I will usually do that within the first few months of starting that when they get diagnosed with metastatic prostate cancer, when I'm giving them ADT.
Okay, okay. So now another question, and we talked about this whole concept of precision medicine, and when you talked about PARP inhibitors, and we about genetic testing. But let's just go back to the earliest point. If you are, whether or not child of a prostate cancer survivor, whether it's a BRCA1 positive or non-BRCA1 positive, when should that child begin testing for prostate cancer?
Yeah. So a key and really important question, because screening is not happening enough anyway for patients, but most of the guidelines, including NCCN, and I think the AUA, I can't remember where the American Cancer Society lands on this, but for patients who are at of general normal risk
Right,
for developing prostate cancer, PSA blood testing should start at age 45.
right.
For men who have a family history of prostate cancer or Black or African ancestry, that should start at age 40.
Mhm.
Now, for men who have a known uh, BRCA mutation within their family, Those are men where you might be thinking about doing germline testing in the family members of that patient who has an inherited BRCA mutation. But nonetheless, those patients should probably be screened starting at age 40 at latest.
Okay. So we know we're consistent with when we talk about screening. So anyone interested is clearly if you have an African ancestry, high risk, genetic mutations, family history, you should begin screening at age 40. And if you're of the general population and no family history, then you should begin screening at age 45. That's kind of consistent with what our stance is at Finn. And I think we talked about this concept, and this is a very important point. I know that a lot of people are still concerned, and then I'll transition over, but a lot of people are afraid and because of what took place with President Biden. Okay, he was diagnosed, didn't get screened, right? And for some years, and he was diagnosed with metastatic disease, metastatic disease in his 80s. What are your thoughts about screening? Because we talked about when to begin, when to end, and does President Biden have a lot of treatment options that are available?
So I can't say that I know anything at all about President Biden's actual story. PSA tests, when was he getting screened or not? It may be in the news, but I certainly didn't find any information about, was he actually getting screened? It'd be hard to imagine that the president was not being screened for prostate cancer. However, I will say that, I fielded a lot of questions from patients about this because how could he be diagnosed with metastatic disease? Shouldn't he have been tested, et cetera? And, the challenge with PSA screening, yeah, I'm sure this group has had conversations about this, that PSA screening is imperfect. And there are some patients who can have a very high PSA and we don't find cancer in them. And then there's some patients with a very low PSA, but we find cancer. So that's the imperfection of PSA as a screening test. It's a really important tool, and we should be encouraging screening in men. But there are limits to what PSA has and can do. And so for my patients who have asked me these sorts of questions, the best I can tell them is that we see it almost every day in the clinic, that there are patients who come in who are young or old, low PSA and diagnosed with prostate cancer, relatively low PSA and diagnosed with prostate cancer, and sometimes diagnosed with metastatic disease, despite having a PSA that's still in the single digits.
Mm.
So it's more it every case is just individualized and different. I couldn't possibly tell you about the president. But when's the right time to stop screening? I think that was the other part of your question, Keith. And I think that that's a challenging one because as people are living longer, the U.S. Preventive Services Task Force had put out this screening guidance saying that patients, I can't remember if it was above 70 or 75, should not be screened at all, period, full stop. And that's in 2012. That's when they also said no one should be getting PSA screening. They've since revised that as of 2018 to say that it should be a conversation with your doctor if you're, 50 or thereabouts, but they haven't changed their thinking about the patients who are 70 or 75 and above. And to me, I think that we see patients all the time who are in their 70s and 80s who are pretty fit and
Right?
and don't have a clear, other condition that's going to limit their lifespan.
Mhm.
And so for those men, I think it's still very reasonable to continue with the screening.